Well, good morning, everyone, and welcome to the Nova Biomedical Breakfast Symposium. I want to wish everybody a happy World Kidney Day, which is today, and I want to thank Ravi, Nicole, and Kirsten, and the other organizers of the conference for putting on an excellent conference and for inviting us to speak here. This morning, we're going to have a few talks from some of the Nova medical directors, and we have a special distinguished guest, Dr. Tiago Reis from Brazil, who will also be presenting. I'm going to be talking about follow-up of acute kidney injury, what's the best strategy, and I apologize in advance because I know there was a lunch symposium on this on Tuesday, so I won't be able to do it justice in terms of what some of the leading experts spoke about, and I also apologize if any of this is a repeat, but we'll go through it fairly quickly because I do think it's an important topic. So we all know that the consequences of a patient who develops acute kidney injury are significant and don't just end in the hospital. Patients who experience an episode of AKI have a two-time incidence of a higher incidence of death than those without, threefold higher incidence of end-stage renal disease, and almost a tenfold incidence of chronic kidney disease. In addition, as you can see, they have an increase in cardiovascular mortality, risk of myocardial infarction, and about a third of them will return to the hospital within 30 days of discharge. Some of the risk factors for worse outcomes after an episode of acute kidney injury are pre-existing kidney disease, patients who have more severe AKI and require RRT, patients with persistently elevated creatinine, diabetics, and surprisingly, it seems that cardiovascular outcomes are not necessarily tied to severity of AKI, but may be more related to persistent hypertension following the episode. In terms of follow-up recommendations, there's not a lot out there. The KDIGO recommendations, which were published in 2012, basically say evaluate patients at 3 months for chronic kidney disease. And that's pretty much it. There's no other specific recommendations for follow-up of these patients, and they haven't been updated since 2012. So there's really, at least in terms of KDIGO, not a lot of clear-cut guidelines. In 2017, the AKI work group did publish some follow-up guidelines for patients with AKI, and they recommended what they described as a layered approach. So the more severe the episode of AKI, the more intense and robust the follow-up. And closer follow-up for patients with acute kidney disease, those with pre-existing kidney disease, patients with persistent proteinuria, cardiovascular disease, and diabetics should get more aggressive and closer follow-up. And some of the issues that they highlighted were post-AKI medication management and nephrology consultation for patients with more severe AKD, but they didn't recommend that necessarily every patient with AKI see a nephrologist. And this is just a diagram from their publication showing that, again, the more severe the stage of AKI, the more aggressive follow-up with a nephrology referral for those patients with the most severe disease. And what are the goals of follow-up? Why is follow-up necessary? And there are a few, and there's some data to support these. So firstly, one of the goals is to prevent chronic kidney disease and certainly prevent end-stage renal disease. We want to obviously minimize mortality and hospital readmission rates, help manage comorbidities. Most of these patients have several comorbidities, including heart failure, other coronary disease, diabetes. Again, medication management is key, and probably the most important is patient education, to inform patients about what AKI means and the significance of it. And you can see the forest plots on the right from this meta-analysis by Steve Coca, who presented at this meeting that the top one shows the hazard ratio for chronic kidney disease after an episode of AKI, and it's about 8.8 times more likely to develop chronic kidney disease after an episode of AKI. And the plot on the bottom shows the hazard ratio of 3 for end-stage renal disease after an episode of AKI. How long should these patients be followed? And then that's also unclear. Again, the guidelines are somewhat not uniform in recommending follow-up. This was a paper from a couple of years back that said that even if post-discharge kidney function returns to normal, any hospital admission with AKI is associated with increased risk of renal progression that may persist for up to 10 years. They also say there's no clear recommendation on the duration that AKI survivors should be monitored after the AKI episode for evaluation of CKD development. Some guidelines suggest a follow-up for 2 to 3 years, even if there's return to baseline function. And I believe the NICE guidelines recommend a 2 to 3 year follow-up. So how are we doing with AKI follow-up now? Well, this is a graph on the left that shows outcomes at 30 days. And you can see that roughly 10% of the patients will come back to the emergency department after, within 30 days after being discharged with AKI. About 20% will be readmitted for various reasons, and about 5% will die within 30 days of hospital discharge from AKI. The most common diagnoses for people being readmitted or dying after this would be heart failure, recurrent AKI, or COPD. Dr. Silver from Toronto and Dr. Su published this paper in 2017, again talking about how well we're doing in terms of following up these patients. And you can see in the graph on the left, within 3 months, it's not bad. About 75% of people will follow up with their primary care physician. Almost 40% will follow up with a cardiologist, but only about 12% within 3 months will follow up with a nephrologist. The good news is that number goes up to 19% at 1 year. So it's still obviously very kind of poor nephrology follow-up, and I think that's one of the things that's been highlighted at this meeting as well, that there needs to be a little more awareness of the role for the nephrologist in follow-up of patients with AKI. In terms of lab testing, only about 60% of patients will have a follow-up creatinine within 3 months, and only about 10% will have their urine checked for protein at 3 months. Part of this may be patient awareness. Part of this may be primary care physician awareness, hospitalist awareness. So if you look at discharge summaries from patients who have been in the hospital for AKI, fewer than 50% will document AKI as a discharge diagnosis. And if you actually ask patients if they've had acute kidney injury, more than 80% are unaware that they've had acute kidney injury while they're in the hospital. There was one study that showed that actually 1 out of 5 patients regularly take NSAIDs following being hospital discharge for AKI. And so obviously we know there's a high risk of chronic kidney disease and end-stage renal disease in this group of patients. So what are the benefits of nephrology follow-up? Obviously, this is not something I need to tell to this audience here, but there has been shown that patients who follow up with a nephrologist will have reduced mortality, reduced risk of end-stage renal disease, and likely a potential for reduced chronic kidney disease, although I don't think the data is particularly robust in that area. And you can see the graph on the right shows the mortality rate in patients who have followed up with a nephrologist versus those who haven't followed up with a nephrologist. And you can see there's a significant difference here. Why is that? Well, again, it's for the reasons that I explained previously. The nephrologist can help with patient education, family education, talk about nephrotoxic medications and adjust dosages or stop medications as need be. possible better management of hypertension, and also early referral to specialists such as cardiologists or endocrinologists to manage coronary disease and diabetes. So how can we do better? There are several publications now in several centers around the world that have follow-up clinics for specifically tailored to patients with AKI, but we also need to educate the providers, both providers in the hospital, hospitalists, intensivists, to make sure that AKI diagnoses get listed in the discharge summary, and that also patients get educated to the fact that they need to follow up with a nephrologist if their episode was severe, and also patient education regarding things like medication reconciliation and things like that. I think we're at an exciting time now because we do have pharmaceuticals that have been shown to help slow the progression of CKD, and there's a lot of talk about these being used for post-AKI patients to see if outcomes can improve in this patient group. One area where I think Nova might be making a difference is we do offer point-of-care technology for measuring creatinine. So you can see our device, the NovaMax creatinine eGFR meter on the right, and it's something that potentially could be used in the home environment by either a visiting nurse or potentially in the future by the patient themselves to monitor their creatinine. And this might be also very helpful either in remote environments or patients where they might have a difficult time leaving the home. It's not yet FDA approved, but we expect it to be released in Europe this week, and hopefully FDA approved in the near future. So to summarize then, I think there's significant room for improvement in follow-up care of AKI. Obviously, I think education is the key, not just for patients, but for the hospital providers, primary care physicians, and also payers. One thing that we haven't really spoken about is with groups like CMS and large insurers. They currently have a lot of guidelines for hospitals where hospitals are penalized, at least here in the US, for outcomes such as 30-day readmission in heart failure, catheter-associated UTIs, central line-associated blood infections. So that tends to motivate hospitals to put structures in place to help prevent those things from happening. And that's one area that advocacy can help with. As I said, nephrology consultation will improve outcomes. Newer medications are showing some promise. Hopefully point-of-care testing will show some benefit. And obviously I'm aware that I'm preaching to the choir here, but hopefully this word will spread out from this meeting, and next year we'll be having different presentations regarding this.